Okay. Hello?
Morning, Michael.
Who's this?
This is Tom, and we're contacting to see if you might have an interest in getting out of your timeshare property. Is your timeshare something you love, or
No, thanks. You can take me off your list. Not interested. Bye.
Hello, sir. Good evening, sir.
Hello, how are you?
How are you, sir?
Good. I was beginning to wonder whether we had audio, but now I hear you.
Yes, yes.
Morning, sir.
Good morning.
How are you, sir?
I'm good. How are you guys? Looks like your participant number is climbing.
Hi, sir. Hey.
Hi, Dr. Sumon, Dr. Lokendra Singh here. How are you?
Yeah. Good evening,
Well,
sir. Good evening. Waiting room off করে দিছো না?
Hi, sir. It's a joint person. Astana. গোয়েল স্যার জয়েন করছে, সালমান শরীফ স্যার জয়েন করছে, ইয়ে করো না, আনমিউট করো না কেন এটা? গোয়েল স্যার চেনো না? সালমান শরীফ স্যার বলছে।
Sir Atul Goyal, sir. Welcome, sir.
Hi guys, how are you all?
Hi. Good evening, sir. How are you, sir?
Good evening. How's everybody? Hi Mike. Hi Atul.
Hi, Salman. Mike is there. I don't see him on my screen. He's there?
Hi.
Cool, how are you? Can you hear me?
Yeah, Mike. What is the news from you? Looking forward to your lecture.
When I see you, I feel ashamed. You've heard this lecture so many times.
Don't say that, my dear
I have
friend.
nothing new to say to you. You've heard this.
You are the hot stuff
Hot property.
in the world of neurosurgery.
Oh, it's good to see you all. Thank you.
Yeah, my pleasure, Mike.
How are you doing over there?
Very good. Slowly, surely, and definitely going out of COVID now. Little bit getting back to normal and doing more than what I was doing a few days ago. So getting back to normal. What about your place?
I think we're back to normal. I think
Really?
we have resumed our OR schedule, and everything is pretty much back to normal. I've been operating the normal routine, and our numbers are way down, so we're good.
Nice to hear that. What about situation in US in general?
Yeah, I've been on vacation for about 10 days, so I haven't been looking at the news, and I don't know exactly where we stand. But I think in general, things are getting more controlled. People are getting serious about the masks finally. The work behaviors have changed. So yeah, I think it's improving.
Where did you go on holidays, Mike?
Hello, sir. How are you?
Hi. How are you, sir? Krishna
Fine.
Sharma, sir. How are you, sir? Welcome, sir.
I'm fine. Thank you. Thank you. Thank you very much. How are you all?
Professor Krishna Sharma, you are fine?
Hello, sir. How are you?
Okay, hello. Yeah, you're doing fine, sir.
Thank
Sir
you.
Goyal,
Pretty
sir.
long time.
How are you, sir? This is Shafiq here,
Shafiq, yes.
sir.
Nice
How
to
is
see you. my
Professor Goyal,
friend.
sir.
Hello.
Welcome, sir.
Thank
Goyal
you.
sir, namaste.
Krishna, oh my goodness. Nice to see you.
Nice to see you too, sir. Nice to see you.
Sure, you want to wait or you want to start?
It's
Time
still-
to start actually. It's 9:01, yeah.
I think better to start.
Should I start? Should I start, sir?
Why not?
Yes, sir. So, welcome everybody to today's webinar on behalf of CNW Bangladesh. It is our honor to have the great man in neurosurgery in this era, Professor Michael Lawton, President and CEO, Barrow Neurological Institute, the largest cerebrovascular center in US, Chairman, Department of Neurological Surgery there. Actually, this name doesn't need any introduction. Who haven't gone through 7 AVMs, 7 bypass, 7 aneurysm books? I think very hard to find anybody in the global neurosurgery community right now. His lifetime dedication in cerebrovascular surgery is unique, having vast experience of around 5,000 aneurysm, 1,000 AVM, around 1,000 cavernoma, 700 bypass, total of around 10,000 cases in his last 22 years, proves his real mastery in this field. He's a great teacher, innovator, philosopher, moreover noble humanity, make him live example of excellence in the history of neurosurgery. I have mailed him around more than 100 times, mostly on difficult vascular cases over the last 4 years. He never said no, always extended his great heart and philosophy, though we never meet each other yet. How noble he is, really grateful. My gratitude to you, sir. And today we have our mentors as panelists who lead South Asian neurosurgery always from front. Konuk Kanti Borua, Professor Neurosurgery, Honorable Vice Chancellor, Bangabandhu Sheikh Mujib Medical University, past President, Bangladesh Society of Neurosurgeons. Moreover, he is guardian of neurosurgery community here in Bangladesh. Professor Chandrasekhar Deo Pujari, Chairman Neuroendoscopy and Neuroendocrine Committee of WFNS, past President, Neurological Society of India and International Society of Pediatric Neurosurgery. Professor Lokendra Singh, President, Neurological Society of India right now. Professor Salman Sharif is the President, Pakistan Society of Neurosurgeons right now. And Professor ATM Mosharraf Hossain is the President, Bangladesh Society of Neurosurgeons right now. And Professor Krishna Sharma, President, Nepalese Society of Neurosurgeons. And of course, we have Professor Atul Goel sir. He is a renowned neurosurgeon here with us. Today's session is going to moderate by Dr. Shafiqul Islam. He is Associate Professor, Department of Neurosurgery, Dhaka Medical College Hospital, Dhaka, Bangladesh. He who always inspires us, pushes us to cross the boundary. Please, Shafiqul Islam sir.
Good day. I welcome all of you to our continuous neurosurgical webinar supported by our beloved Neurosurgical Society of Bangladesh. We already know today our faculty is Professor Michael Lawton. He is a great philosopher, great teacher, and he will be talking on AVM today on the difficult subject in neurosurgery. We are very much grateful to him for his time. And I'm sure this talk is going to be a great motivational talk for many of our young neurosurgeons of this part of the world. As a panelist, we have neurosurgical guardians of Southeast Asian countries, along with our mentor, Professor Konuk Kanti Borua sir. So I think without wasting time, let's start today's session. I hereby want to request Professor Lawton to please start your talk. Professor Lawton, please.
Thank you so much. Suman, thank you for the kind invitation. It's good to see you. You're right, we've never met, but I feel like I know you from all of our emails. It's great to see all these faces from across the globe. It's such a funny time, you know, to be sitting here in Phoenix and to be able to connect with so many of you, Atul in India and all of you so effortlessly. It's really, it's so remarkable. So let me go ahead and share my screen here. And let me know if you're not seeing my screen. My title slide will come up here in just a second. Can you see that?
Yes, sir.
Okay, good. I've been requested to speak on AVMs, which is great because I love these lesions. I've made AVMs in a way one of my life's work. And I kind of bumbled into it because I ended up training in Phoenix with Dr. Spetzler, who, of course, we all revere and we all almost say his name every day in this business because of his grading scale. I've really taken to these, and you know, what's fun for me is to look at some of these numbers and reflect. I've been fortunate to be able to do a tremendous number of these, over 900 now, over my years in practice. And I particularly like the fact that, you know, my account has exceeded Dr. Spetzler's because, you know, he's always been one of those aspirational mentors for me, and I've always tried to live up to his standard and to exceed his total. It's been really important or proudful for me. It's also interesting to just reflect on this number. If you look at the very controversial Aruba trial, and you look at the surgical cases in that study, my personal surgical volume is over 50 times what was reported in that. So hopefully I've learned a few things. I'd like to share those with you. Suman mentioned my book. I guess a lot of people have read it, thankfully. That's always heartening to hear that. I think what the book stands for are a couple of things. One is just this taxonomy of trying to really understand AVMs or put them into categories. I think when we do that, we can understand them as discrete entities and not be lost in the variety and the spectrum of these different lesions. I also wanted to really conceptualize surgical steps in the same way that we do for aneurysms, so that as we go through this very complicated operation, we have a framework to apply to what we're doing. And lastly, the hope was that all the young neurosurgeons out there who are eager to learn this can learn the technique, hopefully in shorter time than it took me to learn how to do this, and go out there and get great results. Because I think if we're ever going to answer the critics of Aruba who say these AVMs should be managed medically, I think our results have to do the talking. So I like metaphors. They're useful to bring these ideas together in ways that are digestible. And for me, AVM surgery, I've liked the war metaphor because I view the neurosurgeon as a soldier. We go to battle with these things, and it's not always easy. It can be very painful. We have to understand the cerebrovascular anatomy, which I view as the battlefield. We have to understand the enemy, which is the AVM subtype that we're dealing with. And we have to have a battle plan, which is these resection steps. So I'm going to just briefly talk on some of these ideas because I think many of you are familiar with these from my writings or the book. This is just to make the point that if you were to look at all the AVMs that come across your practice, your service, either through the ER or the OR, they're all different. There really isn't any one that's like another. They're completely unique. And that can be a very bewildering thing. If you try and make sense of all of that, it can be overwhelming. But I think there is order in this chaos or in this spectrum. And I like to think of AVMs in the same way that we understand animals in the wild, as both having a certain genus and a certain species. And if you think about genus and species, it gives us a way to describe what specific animal you're seeing in the wild. And it's the same with an AVM. If you think about it in terms of its type and its subtype, then you can really boil these down into about 32 or maybe a few more discrete entities. So the types are these 7 types, and they really have to do with the region of the brain, whether it be frontal, temporal, parieto-occipital, deep, periventricular, brainstem, or cerebellar. These are the 7 types or regions that you'll find AVMs, and that is where you start. But then you need to look at the subtype, and the subtype is really based on the surface that the AVM is based on. There seems to be with these things a surface that you can see in some of these drawings here, where the AVM has a discrete surface and it cones down to the ventricle, but that surface where the AVM seems to be based upon, that determines the subtype. So you have all of these different surfaces of these regions that become ways of further subdividing the AVM. So as an example, an AVM in the frontal lobe can be based on a lateral surface, a medial surface, a basal surface, or a Sylvian surface. And it can even be based at this corner here between the lateral and medial surfaces right adjacent to the superior sagittal sinus. And these, in my read, are the 5 different subtypes of the frontal AVM. So almost any frontal AVM that you see can be categorized into one of these groups. Same is true with the cerebellum. If we read Roten's work, he defined 3 different surfaces of the cerebellum: the suboccipital surface, the tentorial surface, and the petrosal surface. And those again define 3 of these 5 different subtypes for the cerebellar AVM. There's the Vermian AVM, which is an additional one because these midline AVMs along this midline region are quite common actually. And quite uncommon though are these tonsillar AVMs down here. So these are the 5 different cerebellar AVMs. And the point of this is not to go through each and every one, but just to say that when I see an AVM for the first time, one of the first questions I ask is what am I dealing with? What type, what subtype? And then I think, aha, I understand what this is. I don't need to think about all the specifics or the unique aspects. I understand in general what I'm dealing with. Now, after we make the decision to operate and we commit to the operating room, then these, I think, are the 8 different steps that go into this resection process. And I think you need to start obviously with exposure, but some of these early steps are really, I think, underappreciated. Just doing a lot of subarachnoid dissection to define planes and develop margins. So much of the work of an AVM removal is this subarachnoid dissection, just as it is for aneurysm exposure. Really understanding what your draining vein anatomy is and how you're going to make the decision which of these venous pedicles to base your resection on. This is critical because that obviously has to be maintained throughout the resection. The attack on the AVM begins with definition of feeding arteries, but then we really don't engage the AVM till this 5th, 6th, and 7th step, where we go from pia to parenchyma to ependyma, marching from superficial to deep and engaging these different planes. Finally, we get to the point where the AVM is dearterialized, it's been freed up from the brain parenchyma, and we can finally remove it. So these are the steps. And within each of these, there's so much that I could say, and I don't have time for that. But just as an example, if we think about feeding arteries, in this illustration, you can see there are so many different types of feeding arteries that are around an AVM. The classic one is this terminal feeder here that comes in here and ends directly in the AVM. These are ones that we can occlude right as they join the margin, and those are really straightforward. But you also have these bystanders that run right by the AVM, have no contribution, and have to be preserved. We have these transit arteries that sweep by the AVM. They give branches that supply it, but also give a distal branch that supplies normal brains. So we have to recognize these transit arteries and make sure we save the outflow. There are perforating arteries that go through the deep white matter, and there are choroidal vessels that come up through the ventricular system. And again, each of these has a different set of properties and dangers that are associated with them. If you get a transit artery, it has its own unique technique. You've got to start distally so that you recognize the outflow and dissect from distal to proximal. If you try and dissect from proximal to distal, you might misjudge the outflow and you might end up occluding that. So this is an example of skeletonization. Here's a artery running in the sylvian fissure, sending these feeding artery branches that's been skeletonized over here. The next thing is the idea of the battle plan. This is a war map from World War II, and you can see the red arrows and the blue arrows. And I've always liked this because when we think about our battle plan for the AVM, you can see here the red arrows and the blue arrows. These are our thrusts, the feeding arteries that supply these in red, the draining veins that we need to preserve so that the AVM doesn't explode. We need to identify those. And then we also need to recognize areas of eloquence, like in this illustration here, the Broca's area. And I wanted to delve into now some of what I call the master concepts, just digging a little deeper below that, the surface here, and talk about these 6 different ideas. And I'll start with the AVM box. So this box, or this cube, I find to be a very nice construct or way of conceptualizing what you need to do and how you can organize the anatomy. The cube basically takes the complex shape of an AVM that's never a cube, but then reduces it to this simple form that has 6 sides. And then in your mind, you can really understand where the arteries are coming in, where the veins are leaving, and where the eloquence is. So that box allows you to map out those 3 features: the draining vein, the feeding artery anatomy, and the eloquence. And in your mind, you can organize where you have to be extra careful, where you can be a little bit aggressive, where you need to respect the parenchyma, where you can be a little bit more aggressive in getting into the parenchyma, and so forth. The dissection steps that we talked about, when you think about them applied to this cube, it means that there's a peel side, which is the top of the cube. There are 4 parenchymal sides, which are the sides of the cube. And then there's the ependymal side, which is that deep side at the bottom. And when you think about it that way, then it helps also organize these different phases of those resection steps that we talked about, those 5th, 6th, and 7th steps. So let me give you an example here of that's interesting. Sorry, I haven't seen this before. This is a annotation thing. Hold on a sec. Okay. So can you see my slide here, the medial temporal AVM? I'm getting some annotations over the slide. Are you seeing the yellow markings?
Sir, yes, sir. Sir, please give me a minute, sir.
Open up I don't know whether that's on my end or whether that's somewhere else, but let me try something here. I'm going to open up a different version of this folder here and see if that helps. Well, I've never seen that before. What I'm getting here is some scribble over the screen that I'm not doing that is obscuring things. Up, there we go. Hold on a sec. It just went away. Now it's coming back. Well, I'm afraid I don't know what to do about that. I think what I may need to do is exit this and restart this.
মুসান নয় নাম ছাড়া সবগুলো একটু ডিসেবল করো তো, ব্লক করে দাও। পারছো এখন?
Tell me what you see now.
মুসান শুরু করবে আবার?
Yes, sir.
আরেকবার শুরু করবে বলো তাহলে।
Yes, sir. Yes, sir. You can start, sir.
Do you see my slides?
No.
No? Oh, okay, hold on, let me try this.
Yeah.
Okay, well, let me see if I could, get back on track here. Okay. All right, so this is an example of a medial temporal AVM. You can see it here in the medial temporal lobe. You can see over here the artist's conception of what that looks like. You can see how a lot of the feeding here is from the anterior carotid artery. There's some feeding from these branches off of the posterior cerebral artery here. And angiographically, you can see what that looks like. Now, here's that cube that I've been talking about that basically shows you the arterial anatomy over here in red, and you can see the draining vein on the back. All of the action here for this particular AVM is on this medial border of the cube. And so that's really where we need to get to surgically. So here now in the video, are you seeing the live video?
Not yet.
No, okay. Let me, maybe I'm sharing the wrong screen. Hold on a sec. All right, how about now? Can you see the video?
Yeah. Yes, sir, we can see the video, sir.
Okay, good. All right, hopefully we'll get through this now. So this is now the transsylvian exposure of this AVM. What I've dissected here is right along the supraclinoid carotid here. And you can see in the center of your screen, the third nerve and a very large anterior carotid artery that is running along that medial side of the temporal lobe. You can see here branches from the anterior carotid, and here now dissecting along the tentorial incisura. The point of this is that as we think about this AVM from the perspective of our cube, we know that all the action is on this medial side. So this is where we go to early. This gives us the exposure of all of this anatomy. This is that draining vein going to the basal vein of Rosenthal. And this is at the very end, just coming across that. You can see how the action was there on the medial side of that cube. This is not a cube, but as when we conceptualize it as a cube, it helps guide our steps in getting to that point that's so important. Here's the view at the end. You can see the carotid, you can see the PCOM and the choroidal, this massive choroidal artery that was dilated from the AVM, and all of these little branches here coming off the choroidal that needed to be preserved are preserved. And you can see down in here, the third nerve, the cerebral peduncle, and all of the vessels coming from the quadriplication, all nicely preserved. The AVM was in this space here. There's the postoperative angiogram. Now, the next point that I think is important is in that list of 8 steps in the AVM resection, the thing that I would say is the most difficult is step number 7, that ependymal dissection. And that's because it's the deepest and hardest to see. As we think about the anatomy of an AVM, it's like the moon. You've got a dark side here that's on the bottom. You can see the top and all the different sides here, but as you get deeper around the dark side, it becomes difficult to see, and it becomes essential to do other things to help yourself, like using retractors, like using these telphas to line the resection bed, like dealing with these parenchymal feeders here that come in and sometimes require the use of these AVM microclips. This illustration here is meant to make the point that you've got to make good decisions in going around that 7th step, or that dark side. You've got to make sure that you don't cut that corner too soon and leave a little nidus here, because if you do, you'll have this ependymal vein, you'll have choroidal arteries that feed it, and you'll have a remnant here that shows up on your postoperative angiogram, and that will mean a trip back to the OR. Instead, you've got to go all the way down, push yourself to reach the ventricle, find those choroidal feeders, find that ependymal vein, and really make sure you get around that deepest portion. So here's an example. This is a paramedian frontal AVM. You can see this enormous deep venous drainage pattern that it has. And so this is one that's going to be a real challenge to get around that deep side. You can see it's got large feeders from the ACA medially. It's got large feeders on the basal surface. And as we look at our anatomy here, this is the type. It's this paramedian frontal. This is our cube. So as we think about this one, here's our anatomy here. Most of the arterial feeders are coming from both laterally, medially, and basally. So you can see arrows from all sides. You can see here the venous drainage tending to go medially towards the sagittal sinus. So here's the intraoperative video. And so the falx is going to be here. This is the basal surface. You can see some feeders coming from below, right around the area of the cribriform plate. Now we're in that medial interhemispheric space, and you can see the feeders coming through the fissure from the anterocerebral artery, and nice occlusion there. So this is basically step 6, where we're going across these sides of the AVM. This is some feeders that come from the dura. But now as we transition to the 7th step, you can see that we're trying to get underneath this thing. We're finding some very helpful encephalomalacia here. There's communication here with the ventricle. And you can see that in order to get into these spaces under the AVM, you have to lift and move the AVM from one side to the next. You have to use your instruments to help lift and move the nidus. Here, finally getting around the lateral side, finding these last feeders here. You can see how it really takes some work to get all the way around this AVM and finally lift it out of the parenchymal space. So this is what I think can make these AVMs hard, is to get around that 7th side, that deep side, and oftentimes there are hidden feeders at the depths that you don't appreciate till the bitter end. Here's his postoperative angiogram. He did well. Now, the next point is about gravity and trajectory. This is an interesting concept where, you know, for a medial AVM like this one, I think most of us would tend to put the AVM on the ipsilateral side. So if we're going to use gravity retraction, for example, we would want to put the AVM so that we're on the same side, looking down on that medial aspect of the frontal lobe. But if you think about what it takes to get around this AVM, the hardest part is really going laterally and around this plane here. This is that 7th side. And if we put the AVM down on the ipsilateral side, this becomes very difficult to do, because we're actually having to kind of lift the AVM up, and it's difficult to see. On the other hand, if we put the AVM contralaterally further away from ourselves, then we change our point of view from almost a vertical perspective here to a more horizontal perspective over here. And we're looking across the top of the nidus. We're looking into this difficult plane here, and the AVM is actually falling with gravity in a way that helps us. Here's these two concepts side by side. Here, the AVM is down. Here, the AVM is up. If we put the AVM down, it's closer to us. It's ipsilateral. We have all of the anatomy in front of us. But to get around this corner, you see you have to go down along that lateral plane and then make this right-hand turn to get underneath. And you're almost having to lift the AVM out of the frontal lobe. Whereas if you put the AVM over here on the opposite side and you go over the top, you see you've got a nice view into that very difficult last plane here. You can see very clearly, you can get those last feeders, and the AVM is actually falling in a way that helps you. So here's a very simple example of that. You can see in the MRI, this is basically in the corpus callosum along the septum and into the lateral ventricle. It extends a little bit to the left. And so what we'll do is we'll put the left side on the upside, actually away from us. And you can see our cube. This is the feeding artery anatomy here from the pericallosal vessels. The draining veins are down to the septal vein, which you can see here, and up to these medial frontal veins. And these are our resection steps through the interhemispheric fissure and through the corpus callosum. And here's the intraoperative video. So I'm separating the pericallosal vessels. You can see this medial edge of the AVM nidus. And these are these feeders here coming off of the pericallosal that I'm skeletonizing. So vessel by vessel, I go down the pericallosals and I dearterialize. This is now getting into the corpus callosum. These AVMs are really quite beautiful because you can see the deeper sides are actually in CSF. This is now a draining vein crossing over, so we have to preserve that. And now we go along this posterior edge. Here's a view down the septum. You can see the septal vein there. We're saving that septal vein here as a drainage. And the AVM now is basically falling towards us. It's, as I go over the top and around that lateral plane, you can see how it just sort of falls into our view and allows me to get around that deep side. It's a little bit more of a reach going across, but the trajectory, the perspective really helps you. And here now, widening that reach into the lateral aspect of the corpus callosum, you can see the deep venous anatomy there. Here's the nidus now, it's been completely freed. It's based upon the septal vein here, which as we lift the AVM, you'll see is nice and blue. There it is there, the septal vein right here. This is the view into the ventricle. And now we can cauterize that septal vein here. And take this out. So that's a simple example of the contralateral trajectory. You can see I've come in from the right, but I'm going to the left. It made it very easy to get around the borders. Here's a nice view of the foramen of Monroe. This is also a pericallosal aneurysm that this patient had as a feeding artery aneurysm clipped at the same time. And you can see here post-operatively a clean result. Diagnosis. Here's a here's another example of that concept with a little bit bigger AVM. So bigger AVM, I've put the AVM on the upside furthest away so that the ipsilateral side drops, or the side that doesn't have the AVM drops away. We can then get into that frontal lobe on the opposite side. And the key here is that in going over the top of this AVM, right in through here, the AVM is actually going to be easier to manage. We have the AVM falling down towards us. Here's a little venous varix, and getting into this space over the top, right here, you can see this is that difficult plane. We're getting around the lateral side, and the AVM nicely just falls into our view. We can see across the AVM. We can get to these difficult to reach portions that are deep. Here are those last remaining deep feeders through the white matter that, had this been on the ipsilateral side, would have been much more difficult to access. So now I'm dividing the draining vein here. The AVM is now completely free, and you can see how this AVM really lifts out nicely from that contralateral hemisphere. there you have it. So a really nice way to do this. It's counterintuitive. It took me a while to come to this, but if you think more about the perspectives and the trajectories, rather than operating on the same side as the AVM, then I think you can begin to see the logic in this kind of an approach. So high eloquence AVMs are the next thing. When dealing with AVMs in the brainstem, for example, or in the thalamus, sometimes it's riskier to actually resect the AVM than it is just to do what I call occlusion in situ. And occlusion in situ is really dearterializing the AVM and then doing a venous occlusion as the last step once the majority of that arterial input has been closed off. And so I'm going to show you an example of that. I'll skip this one and show you I'll show you this one. This is a thalamic AVM. It's a Spetzler-Martin grade 3. It's a supplementary grade 3, so a cumulative grade 6. And when you look here, it's sitting right in that supromedial aspect of the thalamus. This was embolized, this was radiated, and you can see it persists. The majority of this on this sagittal cut, you can see is lying on top of the thalamus and also in the velum interpositum. You can see big choroidal feeders coming up over the top from the PCA. You can see these dangerous transthalamic feeders here in this angiogram, carotid angiogram going through the thalamus. And so these are, I think, the biggest worry, that these would start to bleed during the resection and get away from you. So I'll show you how I dealt with that. This is the surgical view. The patient will again be with the head turned to the side, the midline horizontal. We'll go transcallosal, get into the ventricle. We'll come right down on top of this. And let's go straight to the video now. So this is now the interhemispheric dissection. The pericallosals are coming into view. There's the corpus callosum. We now get through the corpus callosum and into the ventricle. And as we enter the ventricle, we come right down on top of the AVM. So what we see here is these large feeders that come through the thalamic tissue. This is the superior surface. This is the choroid plexus here on top along the choroidal fissure. And you can see these vessels, these draining veins here that line the choroidal fissure. So we're going to go into the choroidal fissure. We're going to pick off these feeders here that come through the thalamus. Here's one that you can see snaking around. This is a posterior choroidal artery that's coming up from the atrium. These are nice to occlude because you can see their walls are quite thick. We can nicely cauterize. This gives us a nice segue into the choroidal fissure. This is that thalamic feeder coming out of the thalamus and into the nidus. Here's a nice view of the choroidal fissure here. You can see the fornix over on this side. And as we get around this lateral border of the AVM, more and more of these feeders coming out of the thalamus come into view. Here's the use of AVM microclips. Because I don't want those to start bleeding, I use those very liberally, and that allows me to shut down the flow, then cauterize, then divide. Here now I'm opening into the velum interpositum. So right now we're looking back into the roof of the third ventricle. Here's another large feeder coming from the region of the foramen of Monroe on the anterior aspect of this. Again, liberal use of these AVM clips. And slowly, artery by artery, we're dearterializing this. Now, as we think about getting to the end of this, what we need to do is we need to look at the vein. And so as I go into the posterior roof of the third ventricle, we'll look for the internal cerebral veins. This is now looking down into the third ventricle. You can see thalamus here on both sides. You can see this embolized carotid artery with some onyx inside. And now as we look back, this is our internal cerebral vein in the back. And you can see it's pink maybe a little purple, which means that we've done a pretty good job of dearterializing this. I'm just going to skip this part. This is just looking in the other ventricle. But here now, here's that internal cerebral vein that you now see draining the AVM. And what I'll do is this IC green. This is a way to see how much residual flow is going in that vein. You can see the vein right in here. It does have some flow. It's pretty slow. That tells me that I've done a decent job of dearterializing this AVM. And I feel comfortable now putting a clip on that venous outflow and doing a venous occlusion. So this is now the aneurysm clip that's closing the vein. So we've dearterialized this thing. We've now done a venous occlusion. When we do our next IC green run, you can see there's no longer any shunting out of the AVM. So we've basically treated this. Now I'm going to leave the AVM in there because I don't want to damage the fornix. I don't want to damage the thalamus. You can see AVM here. It's really just a dead nidus with a vein here that has nowhere to drain. It's closed by the clip. The vein is dark. It continues on to the galenic complex, but there's no redness there. There's no shunting, and we can leave this in situ. And I'm going to show you the angiogram here next, and you'll see we've got a beautiful angiographic result. There's no shunting in this. It's cured, and this patient's a number of years out from this. Another example of a high eloquence AVM is this one. This is in the cervical spinal cord. You can see she presented with bleeding. You have a little bit of encephalomalacia around this thing. And here's the angiogram, really sitting right on the substance of the spinal cord at a very high level. If this doesn't go right, you could very easily leave her quadriplegic. So this is just a view of the myelotomy being done here. So I use my bypass instruments because they're very precise. You can really accurately spread the tissue of that median raphe, which takes me right down to the AVM. And what I wanted to show here is that, you know, you're working through such an eloquent area. If we don't manage the tissue well here, we could very easily leave her with profound deficits. And so what I do for these spinal cord AVMs is I treat them more like a cavernous malformation. I try and, as you see here, kind of pull the AVM, separate it from the tracts and the important tissue in the spinal cord, and I handle it a little differently than I would a brain AVM, where you're dissecting the plane and staying in that margin, but sometimes getting into parenchyma. In the spinal cord, obviously you can't do that. There's really no margin for getting into tissue, and so you have to be a little bit more aggressive with the nidus itself. You can see here I'm pulling it to the left to free it from that plane. That sort of shows me I'm using sharp dissection to break apart these adhesions, and it's a different style of resection. And I want to show you this next sequence. This is me getting into a little bit of trouble, some bleeding, but it shows you that, you know, if you do get bleeding, you can just stay on it. Here, this artery will start to bleed. It's a very small hole, so it makes it difficult to see. But if you dry it up, find that bleeder with your sucker, and then stay really focused, laser focused on that spot, you can find that artery that's bleeding, you can cauterize it, and you can control it. Here we are just mobilizing the nidus again from the anterior part of the border here, really rolling that to develop that dissection plane. You can see the sharp dissection going on. And again, it's more like what we do for a brainstem cavernous malformation, teasing it away from the separation planes, than it is the traditional brain AVM resection technique. So here are some of the final feeders. I've worked my way all the way down to where the anterior spinal artery feeds this thing. And you can see at the very depths of this, I'm all the way at the arachnoid, that peel layer on the anterior surface of the spinal cord. So here, just making our final final snips here, the AVM becomes free, and we take it out, and we can see there a nice dead nidus. Good preservation of the tracts that are adjacent to that, all working through a fairly small midline myelotomy. So here's her postoperative MRI or postoperative angiogram. We got a curative removal here, and she's gone on to really do well. Bleeding from AVMs can be painful. I call it the hurt locker because you get into a situation like this. These are like diffusing bombs, but when you get bleeding, you can think about it as three types. You have to ask yourself, is it arterial? Is it nidal? Is it from a venous occlusion? Arterial bleeding, as vigorous as that can be, is always manageable. You just have to keep working yourself more proximally on the artery until you get control of that arterial bleeding point. And then you can handle it. If you penetrate the nidus, that's also reasonable to deal with. You can just tamponade or cover that penetration point and keep working, and you can work beyond that. The venous occlusion is a big mistake. If you inadvertently close the venous outflow to the AVM and the entire nidus swells and ruptures, then you have bleeding from multiple sites, and that's a real problem. You have to aggressively resect the AVM quickly, what I would call a commando resection, and that I think is a real test of your fortitude. I'm going to finish up now, since I'm getting to the end of the hour here, with just some comments about developing skills, becoming a master at this, just for the young neurosurgeons, you know, what lies ahead for you. I think that a lot of what I think it takes to be a good AVM surgeon is operator ability. And, you know, I was fortunate to watch Dr. Spetzler and be trained by him in my early years. And I realized that there's so much that goes into that operator ability. It's the delicate touch, being perfectionistic about your moves and your plans and your execution, and really focusing on the results, looking carefully at what works, looking carefully at what doesn't work, and constantly refining. Anatomy is so critical to operator ability. If you understand that battlefield and you know all of the landmines, the landmarks, can use the information that the brain is giving you, then you become a better surgeon. You've got to know the 3D relationships. You've got to really study these nuances. And I think there's just no substitute for learning anatomy as much as you can to the highest levels. Now, part of becoming good at AVM surgery is good judgment and good strategy. And that I label here as inoperability. You have to know that line that separates the operable AVM from the inoperable AVM. And I think so much of what Dr. Spetzler did in this grading system and what we've been focused on in some of our research is really defining that that operability, inoperability divide. Because if you're going to have good outcomes and good results, it's really about your case selection. This is an interesting graph. I looked at all of the supplemented Spetzler-Martin grade 7 AVMs. So that's the combination of the Spetzler-Martin grade and the supplementary grade. And I've always felt that anything that's 6 or less is operable. Anything 7 or greater probably shouldn't be operated. But what I show you in this graph is all of the grade 7s that I've operated on, all of the grade 7s that Dr. Spetzler operated on. And my hypothesis was, well, that maybe, you know, the cumulative experience over decades would allow us to show that experience allows you to push that boundary further out. And in fact, it doesn't show that. If you look here over time, you know, there really isn't any rise in that curve. It's very flat, which means that these high-grade AVMs really are formidable AVMs. They aren't to be trifled with. They really need to be respected. And no matter how good you get as a surgeon, sometimes it's just too much when you get into those higher grades. So I say that as a cautionary tale. This is a graph that shows this concept of the operable AVM. Here, the grades, these are what we call the intermediate grades, the grades 5s, 6s, and 7s. And these are all the grade 6s and 7s. You can see, if you look at that line between 6 and 7, you know, there are some grade 6s that I think you need to be careful of. They're what I call the large, older AVMs, the AVMs that get high points for size or for age. They're also over here on the 7 side. These are the grade 7 AVMs. There are a couple, the ones that are small and young, that actually do fairly well. And so there are a couple there on the 7th side that you can tackle. And this concept is really shown here. The 6+ is the grade 6s that are a little bit more dangerous, the older and the larger ones. And these are all of the different subtypes. The grade 7-, there really are only 2. These are the younger, smaller grade 7s. These are ones that you probably can consider operating. But lastly is, you know, what I call the black box, or the personal traits of the AVM surgeon. And surgical courage is something that we don't talk about a lot, but it takes a lot of courage to do this surgery. It can really beat you up. It can deliver some pretty nasty morbidity and complications. And I think it needs to be stated that, you know, you have to be tough to do this this surgery. When you have problems, I think it's important to accept some failure, to think about why things didn't go well, to be resilient and not let it keep you from going forward. And this idea of redemption, you know, getting back in the saddle and learning and applying those lessons that you take away is really important. It helps honor the fallen patients, helps teach the young residents, and it helps make the surgeon even better. So I've talked a lot about boxes. We've talked about cubes for AVMs, but here's that black box for the neurosurgeon. And I think inside that black box is so many of these traits that are important: judgment, selectivity, anatomical knowledge, your strategic sense, your technical skill, the courage, the stamina, your risk tolerance, your fearlessness, the support you have in the team around you. These are all of the things that go into successful AVM surgery, and every person is different. Every surgeon has a different mixture of these different ingredients. And I think that's what makes this specialty so interesting, is to see the different qualities in different surgeons. So I'll leave you with this. You know, I've always said it's the hands, it's the head, and the heart. Spend time developing your dexterity, your technical skills, your touch. Use your head. This is no easy game. You have to be strategic, you have to be creative, you have to exercise good judgment. And finally, heart. It's a tough business. There are a lot of defeats. There's a lot of agony here. It takes grit to keep going. You have to deal with the ghosts, those patients or those mistakes that live with you and haunt you. And I think it takes this constant striving for perfection. So these are some of the concluding thoughts. I've said all of these in the lecture, so I won't repeat that. But anyway, we're at the end of the hour. I just want to again thank you for inviting me. This is nice to be with you, and I hope this was helpful.
Thank you, sir. Thank you for your brilliant talk. I apologize for the disturbance created by some of the friends. It was a beautiful talk, Professor. I'm confident all neurosurgeons, especially young surgeons, learned a lot from your talk. So now I'd like to take some comments from our panelists. First, I would like to request Professor Chandrasekhar Deo-Pujari, for your valuable comment, please. Professor Chandrasekhar Deo-Pujari.
Dr. Lawton, it was wonderful to hear you. I had an occasion to listen to some of your talk this morning, that is last night in United States, when you spoke on the I think, the Neurosurgical Atlas Forum. So it was a very a nice continuity. And I think two of the cases which you showed, which have greatly impressed me. One is the contralateral approach, of course, uh, where you showed a different dimension to control the AVM. And I thought that was really wonderful. And the other was to get the proximal lip of Sylvian Fisher AVM, where sometimes it can be very difficult to recognize the feeders, especially from choroidal. My question is, do you use for such occasions, do you use ICG at all? Do you find that useful in AVM surgery?
Yeah, it's a good question. I I find that the icy green is helpful at the end of the case, more so than at the beginning or during the case. It gives you a read on how far you've impacted the flow. Sometimes if you think you're halfway through the AVM and you do an icy green, you may find that it's still got more life than you think, or you might get to think that you're close to the end, but you do the icy green and you see pretty vigorous flow. And so it can tell you not only just how far along the pathway you are, what I call the odometer, but also it can tell you what region of the AVM is still active. So I think it can be useful for that. I don't use it for what you were suggesting, which is to differentiate the arteries from the veins. It can certainly do that, but the shunting through the AVM is often so fast that you can get misled. An artery that rapidly fills a vein can make the vein look like an artery, and then you can get into trouble. I think what's more valuable to me is, and hopefully you appreciated this on some of my videos, is that I operate at the highest magnification that I possibly can. And when I have that magnification, then I think it's possible to look at the vessel wall to almost see the difference between the vein and the artery in its constitution. The arteries are smaller, they're thicker. You can tell that the color's a little different. They're pinker rather than redder. The veins are thinner, more translucent. You can see their larger caliber. You can often see the turbulent flows inside. And just by looking at that microscopic detail, I think you can almost tell just by your microscopic observation the difference. And that to me is much more intuitive and comforting.
Thanks. I think I'll leave the other question to the other panelists.
Thank you, sir. Thank you, sir, for your beautiful comment. Now I request Professor Lokendra Singh, President, Neurological Society of India, for your valuable comment, please.
Thank you. It was a wonderful talk, Professor Lawton. We have heard you multiple times. Your books are well read, well known to all of us. What I liked was very much, because there is hardly anything to add from my side, because I don't really do so many AVMs, so I can't really add much to it. But basically, a philosophical approach that your self-actualization and what is your operability, what is your capability, how much one can do. I think that is the most important thing, that one should know what AVMs one can excise and what one cannot excise. And I think for the young neurosurgeons and who are doing less common, I think that is the most important thing, because this is a highly specialized branch. It cannot be done just like, as a casual case once in 3 months or 6 months. So I think if you do it regularly, then only one should try to indulge into vascular surgery.
Yeah,
I think
that's right. I think for the young neurosurgeons, there's a big difference between a grade 2 AVM and a grade 3 or 4 AVM. And I think as we begin our careers, it's helpful to start with the simpler ones where you can learn some of these concepts, you can get a confidence in your ability and then progress. And I throw in all the stuff about the boundaries because it's tempting to try and push yourself beyond, if you think that you're gaining skill and you're gaining that confidence, you can exceed what's safe. And I think it's an important reminder that there are these limits with AVM.
Thank you. One more small question, if I can ask. The use of retractor. I mean, I personally don't use retractors, but many people still use retractors in these cases, which are deeply situated AVMs. What do you say? I mean, how much the retractors are going to harm or hamper the blood flow and perfusion and all those things? Any comments?
Yeah. The more I progress in my career, the less I use retractors. But I think there are some things where retractors really can be helpful. You know, for most aneurysms, you don't need retractors. For AVMs and for bypasses, I think there are clear cases where you need it. And I don't think there should be any shame in using it because as I talked about in that 7th step, that dark side of the moon, sometimes you need to free your hands to do good work, and just a little bit of retraction, a little bit of a pull on the AVM to see underneath can really enhance your ability to see and to do the good work. If you don't use it just because of principle, then you might compromise what you're doing. With bypass, the same thing. It's hard to use dynamic retraction when you're in a deep hole and you're trying to do a complicated bypass. So in those situations, having a little retraction can be beneficial. So I think the short answer is that it's generally good principle to minimize retraction. I view it now like a temporary clip. You know, you should use it when necessary and for as limited a time as necessary.
Hello. Yeah. Thank you, sir.
Thank you.
So now I would like to take the opportunity to invite Professor Atul Goel to have few words on today's topic. Unmute karo Musanna. Unmute him, please. Unmute him, please. Musanna. Sir is muted, Musanna.
Okay, Mike, it was a great lecture as usual. Your humility and your dexterity and all those things combined make you a very favorite neurosurgeon of the world. There is no question about it. The other thing is for AVM, one message that is very clear and very loud is that surgery is a very important treatment, and probably the only treatment for AVM is surgery. And surgery is not easy. That is the message that we have to have, that surgery for AVM is not easy. Surgery for AVM is actually the last chapter of neurosurgery. You have to know when to operate, and you have to know your own self, whether you can operate. You have to know yourself what are the needs of the patient, whether he actually needs the surgery. You cannot operate for a situation where only giddiness is the issue or headache is the issue and you create hemiplegia. That is not what is required for the patient. Most important is that we should know, and we should know it very clearly much before the operation begins, that we can actually be able to operate this AVM, whether surgery is possible and whether it is possible to complete the operation. Absolute meticulous preparation for surgery, which arteries to take first, which arteries to take next, which veins to avoid, which veins to completely avoid, which vein has to be taken at the end of the surgery, has to be meticulously prepared. And I have to, despite the experience of anybody, I would like to ask, what you have seen is a nice clean dissection and nice clean removal, but this comes at the very terminal stage of your experience. Even with that experience, there are situations where you land up with extensive bleeding from here, from everywhere, and you land up in a situation where you cannot control the situation. I would like to ask Mike as to, do you actually get into those situations where bleeding control is difficult or becoming impossible for you? What do you do at that point of situation? That is one question. The second question is, out of the 100 AVMs that you see in your neurosurgical life, how many you find that they are beyond you. You cannot touch them. You should not touch them. At your level, how many you say they are inoperable? These two questions I want to ask you.
Yeah. Well, yeah, those are great questions, Atul, as always. I think that it's fair to say that even though you operate on, like I have, AVMs for decades, for 23 years, I still have rough goes with AVMs. And sometimes it's just some deep feeders that are really pesky. They won't coagulate. They bleed ferociously. It could be some kind of a mistake, an early occlusion of a vein or what have you. There continue to be cases where I feel like, this is not how I'd like this to be going, and I don't feel comfortable. That's what AVM surgery is. You don't have the luxury of controlling them, and it's very much like aneurysm surgery, particularly ruptured aneurysm surgery. There's going to be a certain percentage, and for aneurysms, it's probably somewhere 7 to 15% of subarachnoid hemorrhage patients that will re-rupture during your operation, and you just have to be prepared to deal with those re-ruptured aneurysms. And the same is true in AVM surgery. There's going to be a certain percentage, maybe the same numbers, 7 to 10%, where it's going to be a rough ride. And sometimes it's even unexpected. It can be a small trivial AVM that just has a deep feeder that you can't see, or that is right next to the descending motor tract. I mean, there's so many ways that these things can bite you, and it still happens. I think when you get into trouble, it's a little easier as you get older, because we the older surgeons on the panel have had the benefit of getting out of a lot of trouble. So we know that we can do it. I've never had anyone of these AVM patients die on the operating table. I can vividly remember a handful of cases that were pretty nasty, where I was losing liters of blood. But those are few and far between, and were very early in my career. I think there is an intuition, a sort of a feel that you get for this surgery, like any, and that really helps. I wish I had a better way to impart that to the younger surgeon, but making good decisions every step of the way is really important in keeping that from spiraling out of control. Now I've forgotten your second question.
Second question is, you know what, as you have said, that it is such importance, such great importance to decide beforehand that yes, I can do it. Because you cannot take a decision during the operation. Here, there is no partial resection or incomplete resection. You have to go and you have to complete the job. Whether I will be able to begin to complete this decision matters. In how many cases you think out of 100, you think that, no, this is beyond me, I will not like to operate. So because my question is directed to you, because at your stage and at your stature in neurosurgery, you are saying, say, 10% or 15%.
Yeah, I wish I had that number. That's a number that I don't actually have, because I don't, the way I keep my records is I keep records of everything I do, but I don't keep records of the things that I don't do. So I don't know what that is. It's a great question. I would say it's probably about 20 to 25% of all the AVMs that I see, I decide I'm not going to operate on. And I came to that conclusion probably 5 or 7 years into my career, when I had the belief that the better I got, the more I'd be able to do these things, that I could do more and more AVMs. And then I realized that, you know what, I wasn't having fun doing these huge, nasty AVMs. It wasn't fun in the operating room. It wasn't fun post-operatively when I caused a deficit and had to explain that to the patient. It wasn't fun when people were, looking at those patients and questioning my judgment. So I realized that, we have to, we really do have to set those limits. And that's why in those couple of slides that I showed you, those numbers, that 6 to 7 transition, that boundary zone between 6 and 7 is really helpful. Like for me, I think if you just rely on Spetzler-Martin grading and draw a line after 3 between 3 and 4, that's not good enough. There are a lot of grade 4s that are worth taking on. And there are some grade 3s that aren't worth taking on, for example. But if you use the combination of Spetzler-Martin and the supplementary and think of these as supplemented Spetzler-Martin grades and draw the line between 6 and 7, it gives you a very good way of getting all the ones that you should be operating on and staying away from all the ones that you shouldn't be operating on.
Another small question before, what is your take on normal perfusion pressure breakthrough concept, which Spetzler has initiated, and he has told the entire world about this concept? What is your take on this?
Yeah, well, it's interesting because having trained with him and now sitting in the chair that he used to occupy at the Barrow, I've had a long time to observe him and listen to his lectures and hear his ideas. He almost never talks about normal perfusion pressure breakthrough. I think as a concept, it makes a tremendous amount of sense. I think in practice, you don't see it. I think a lot of the postoperative hemorrhages that I see in my practice are because I've left some residual behind, and I know it. It's not because of the normal perfusion pressure breakthrough theory. I think reading between the lines of Dr. Spetzler's behavior, I think I'm not sure he believes it either anymore. And so I don't know that it's one of those concepts that has stood the test of time. It's interesting and it's very logical, but I think that the problem of bleeding after AVM resection has to do with hemostasis and bad decisions about the planes and having left diffuse elements of the AVM.
Before I leave you, last question. How do you, at the end, as you mentioned, it is very important to resect it completely and not to leave any lesion behind, because that forms the basis of bleeding and that basis of clot and that basis of complication. What is your strategy to assess that you have actually removed it completely? What are your parameters?
There's nothing better than the vein. When you look at that anatomy and you decide, okay, this is going to be my draining venous tail that the whole resection of the AVM will be based on, you can see that thing go from really hot, fiery red to blue and basically dead. And that to me is the ultimate. And at the end of a case, I like to leave the AVM just dangling on that tail and pull it out. And I know at that point that it's completely out. That to me is the best guide. I think all of these other technologies, IC green or a hypertensive challenge or any of these others, I think pale in comparison to just having done a meticulous dissection and watch that venous tail go from fiery red to static blue.
I wanted to actually ask the question about these small vessels, which you said that difficult to coagulate and difficult to handle. How do you handle them?
Yeah, well,
if it bleeds in the depth, then what?
The first thing is to recognize where they are and be prepared. I differ very strongly with Michael Morgan, who put forth this idea that you should go straight to those deep feeders and attack them early. He calls it diving to the nose cone. I actually have the exact opposite approach. I like to figure out where that zone of these, what Charlie Wilson used to call the red devils, are going to be, do everything except that, so that when I get to that zone, that patch of red devils, that's the very last thing that I have to contend with. And when I'm there, it's a matter of seeing whether they're cauterizing. If they're not cauterizing, then I quickly revert to the microclips, and then I'll, if they're not behaving, then I'll put the microclips on before I even coagulate. So if you get to a red devil, put on the clip, then cauterize and divide, and then keep going. And so the liberal use of clips, I think, is the way to work through that minefield of those red devils. If they bleed and you have to keep, if one is popped or exploded and it's bleeding on you, you just have to keep chasing it. I think the only answer is to get your suction so that hopefully you can actually suck the end of the vessel into your sucker tip, and that will dry the field, show you the neck of that bleeding vessel, and then you get the clip on. And that's, I think, the best way to handle that. And if that fails, you just keep marching deeper and more proximal. And where you get into trouble, of course, is that all of those vessels live in the white matter, so it's drawing you next to the internal capsule or to the thalamus or wherever that is, and you get into trouble quickly that way.
Thank you, Mike.
Yes, sir. So now I would like to request Professor Salman Sharif, President, Pakistan Society of Neurosurgeons, for your comment, please.
Thank you, Mike. I think that was brilliant. Enjoyed it all the way, and some of the things that some of the techniques you went through, really good to see them as well and learn from you. What I wanted to ask was, what you talked about, having good judgment, good decision making, and then pushing the boundaries. That is the mastery, but that's one thing. What about for people who are starting out? How do they learn the mastery? How do they go about it? How do they select? It's for young neurosurgeons. How would you go about telling them what to do? Where do they start from?
Yeah, well, it's like riding a bicycle. You never just get on a bike and ride up a mountain on a mountain bike. You start with training wheels, you ride in the street, then you start doing some uphills, and then eventually you get up out on the trails and climbing mountains. And I think it's the same with AVMs or with bypass surgery or anything that you want to talk about. For the young neurosurgeon, start with some unruptured AVMs, some ruptured AVMs that are small, that are superficial, that have low grades, and then work your way up the grading spectrum. And those will get you into deeper locations and larger sizes and more eloquent areas. And you slowly learn, what you can do, what you can't do, what you're ready to do, where you need work. You need to, the part about challenging yourself is really important because, if you're too cautious and you don't push yourself beyond the training wheels, so to speak, or off the streets where the pavement is smooth, then you don't become a master. You don't get yourself into those situations that really mature you. And so I think there's a very fine line between, getting yourself exposed and experienced, doing it in the right schedule, not too fast or too slow, and carrying it as far forward as you can. I think all of that stuff is just a really delicate dance that we all have to figure out. And I think part of this process is just loving the surgery. Like if you don't enjoy taking out AVMs, then you probably won't get very far along that journey. If you really like it, then it really sucks you in. It becomes a joy. You realize you can take out some pretty nasty AVMs. You can bring a lot of curative happiness to patients around your region, and that's a nice thing too.
Okay, thanks.
Thank you, sir. Now I'd like to request Professor ATM Mosharraf Hussain, President, Bangladesh Society of Neurosurgeons, for your valuable comment, please. Professor ATM Mosharraf Hussain, please. Sir, please.
এই মুসান্না স্যার মিউট করো, তাড়াতাড়ি আনমিউট করো স্যার, তো মিউট করো দেখতেছি। মুসান্না, মুসান্না।
Sir, I'm meeting him, sir. I will.
Sir, can you unmute yourself? Can you unmute yourself, please? Pranos, just help.
Sir, thanks.
Meanwhile, can I take the comment from...
Sir, I have unmuted Mosharraf, sir.
Sir, please.
Hello, can you hear me now?
Yeah.
Yes.
Yes, sir.
Oh, okay. Thank you very much. It's our pleasure that we have a great man in neurosurgery in Bangladesh. highest level of webinar by Professor Lawton, particularly a super specialty aspect, and along with the most dignified panelists like Professor Deo Pujari, Professor Atul Goel, Professor Salman Sharif, and others. And I must say that in Bangladesh, the situation and scenario is a little bit different, because this super specialty, the cerebrovascular, actually neurosurgery is developing, and we are have the learning curve. And I must agree with Professor Lawton that the young and the energetic group will be able to take over, and they have to get the mass enough experience to learn the situation and to tackle the situation. And I just I have a question in my mind that Professor Lawton, is there any role of embolization, particularly any adjunct or any auxiliary role in this management, particularly surgical aspect? Can it help embolization?
Yeah, there's no question that there's a role for embolization. I think that for the larger, higher grade AVMs, the grade 3s, there's clearly benefit. We just did a review of that, and we found there to be a statistically significant benefit to embolization in the grade 3 AVMs. For the lower grade AVMs, the 1s and 2s, maybe not so much. And I think you can be much more judicious in your use of embolization for those. There's also a paper that we published a few years ago just showing how, as the years went by in my career, I used embolization less and less. I think that's another part of this whole skill development idea. The better you get, the more comfortable and confident you get, the less you need embolization. So again, for the young neurosurgeons, don't hesitate to use it early. As you get more confident, you may not need it so much. But when you do get to the medium and higher grade AVMs, it is incredibly valuable and should be used.
Thank you, Professor Lawton. Thank you again for such a wonderful deliberation. Thank you.
So now it's time, Professor Krishna Sharma, President, Nepali Society of Neurosurgeons, for your valuable comment, please.
Yeah, thank you very much. It was a great lecture, and I think that the combination of head, heart, and hand was really a very nice illustrated, though it is applicable to all neurosurgical problems. I think it is so much applicable to AVM. Thank you, Dr. Lawton. And it was constantly in my mind that there are a few neurosurgeons who are operating AVM in Nepal, but I wish the youngest had more chances to listen to you and interact with you, so that they are more guided, as you have emphasized again and again, how you learn from your mentor. I wish the young neurosurgeons get an equal opportunity to interact with mentors like you. Yes, thank you very much. Thank you.
Thank you, sir.
Thank you. I will say this. This world that we're living in today is becoming so interconnected. And, for those of you in Nepal who maybe don't have the mentorship that you're looking for, things like Twitter, for example, or Instagram are great ways to connect. I can tell you that in the midst of the pandemic, I've been posting videos, 3 of them a week, just to put out some cases so people can see what we're doing here and learn from the cases that we see here at the Barrow. And I would encourage the young neurosurgeons who want more of that exchange to follow me on Twitter, to find others on Twitter that they're doing the similar type of educational work, and connect in whatever ways possible, because those little connections can go a long way.
Thank you, sir. Can I ask you a question? In case of ruptured AVM with good sensoria, what is your strategy? Do you operate immediately, or you want to wait for a couple of weeks? Sir?
Well, with a ruptured AVM, sometimes you're forced to operate because the hematoma can be compromising. But if not, then there is a little bit of a benefit to wait sometime. I usually don't wait long. It's just a couple of days for the clot to liquefy, for some swelling to go down, and for the patient to be a little more stable. I've never liked the idea of sending a ruptured AVM home and waiting 2 to 4 weeks or whatever some people wait. I think it's a little bit disruptive. Patients, they feel uneasy, and they're living with this fear of a rehemorrhage. So I generally will operate on patients within that first week of their hemorrhage. And the hemorrhage itself, the clot, can be very valuable in taking these out. Sometimes a clot next to an AVM can have already done some of the dissection, maybe a lot of the dissection for you. And when you go in there and evacuate, it really helps define a border or accelerate the whole process. So I think you should always think about using that to your advantage.
Thank you, sir.
Can I ask a complimentary question to you, sir, regarding these issues? So we have got 2 patients. That patient undergone re-rupture during this waiting period. So the strategy to wait for a few weeks to deal with the AVM rupture, is it okay, or we should rethink on it, sir?
Is against.
Yeah, I generally don't wait weeks. I'll wait days to operate, and so I've always felt like it's not a good thing to wait weeks for exactly what happened in your case, to have a re-rupture just because you're waiting for a little bit of brain swelling to go down or for the clot to get more liquefied. I think that generally isn't all that helpful. I think what can be difficult is if you've got a very eloquent AVM and you operate in the acute period where the brain is really soft and edematous, that can cause problems. The same thing can happen with aggressive embolization with onyx. Sometimes the onyx can be real inflammatory to adjacent brain, particularly if there's extravasation, and then you can have edematous brain that's hard to really meticulously dissect. So those are things to be cautious of if you're operating early. But in general, though, I do think it's probably better to operate sooner than later.
Thank you, sir. So now we are almost close at the end of our session. Actually, it became neurosurgical virtual reunion of South Asian neurosurgeons because of you, Professor Michael. So now I would like to request Professor Konokkanti Borua. He is Honorable Vice Chancellor of Bangabandhu Sheikh Mujib Medical University. He is our mentor, he is our guardian actually. He was President of Bangladesh Society of Neurosurgeons. To say a few words regarding today's talk, and also I'd like to request you to make concluding remarks of today's webinar. Please, sir.
First of all, I want to congratulate Michael Lawton for his wonderful lecture. I have thoroughly enjoyed his lecture, as well as I am spellbound by seeing his surgical craftsmanship and the way he has operated in AVM in many locations, in different locations. At the same time, I am very much grateful to the organizers. It has given me the opportunity to meet my old friends like Atul Goyal, Dev Pujari, Professor Dev Pujari, Salman from Pakistan, as well as Lokendra and Dr. Lokendra and Sharma from Nepal, as well as my colleague here is President Professor Musharraf. I want to ask Professor Lawton, I want to ask you one question. That is, a patient in older age group who have seizure, but who are otherwise neurologically intact without previous history of hemorrhage, comparatively have a smaller cumulative risk of major morbidity and mortality with continued conservative treatment. What is your opinion?
Well, yeah, I think the question is, if a patient just has seizures, should we be operating? And I think that we've studied the seizure cure rate after AVM surgery, and it's quite high. Patients who are on anticonvulsants, something like 80% or greater can come off of anticonvulsant medication. And I think it's because even though these patients may not have symptoms, they have what we have described as silent microhemorrhage, where you have these silent hemorrhages that get iron in the brain, they irritate the brain, and they injure the brain, and can produce this ongoing seizure focus. And so getting that out and reversing that cycle is really important. And I'm a believer in operating for seizures, particularly when the surgical morbidity profile is low. If you have a risk of 5% or less, and you can cure the AVM, protect them from hemorrhage, and get them off anticonvulsants, then I think it's a worthwhile thing to do.
Thank you. Thank you. I at the same time, from Bangladesh, if we send some young neurosurgeons to have training facilities in your center, will it be possible?
Of course it is. We've had an observership program in place forever. We've had guests come to the Barrow from when I was a resident here to all the way up until the COVID pandemic. We have had to put some of that on hold because of travel restrictions and so forth. But we do have an observership program. As soon as the pandemic problem is over, then that will be back in force. And we would love to have your residents, your young neurosurgeons, love to have them come. We also, as I said earlier, are doing a lot on our website to promote education without all of these travel problems. And so, if you want to see operative videos, if you want to learn from some of the work that we're doing, you can go to our website, barrowneuro.org. You could go to my Twitter feed at MT-Lawton. And there are things there that can continue the whole conversation, the whole teaching process in the midst of all of this. We're really keen on that. And, I've always felt like it's our duty to elevate the young generation so they're ready to carry the mantle when we're ready to pass it on.
Thank you. Thank you. I had an opportunity to visit Barrow's Neurological Institute 22 years back when Professor Spitzler organized the North American Skull-Base Conference.
Yeah.
Yeah.
I remember.
Thank you. Thank you, Professor Lawton, for your wonderful lecture again. Thank you very much. At the same time, my friends from Southeast Asia, from India, Pakistan, and Nepal. Thank you. Thank you all. Thank you. Thanks to the organizers.
Thank you for
having me. Thank you, Professor. Thank you. Thank you,
Great.
Professor. Thank you for your time.
Thank you.
Thank you, sir.
Thank you. Thank you, everyone.
Thank you, everybody, sir.
Thank you, sir.
Bye-bye.
Thank you, sir.
Thank you. Shafiq, thank you very much.
Thank you.
Unwanted কিছু event হয়েছে।
Thank you.
Thank you, sir.
Unwanted কিছু event হয়েছে, আপনাদের কিছু করার নাই।